अस्सलाम वालेकुम सर।
आवाज आ रही है मेरी?
जी सर, क्लियर। मेरी आ रही है?
जी बिल्कुल बिल्कुल क्लियर आ रही है।
ओके, इट्स
चलें, विल वेट फॉर, अभी तो 5 मिनट्स विल वेट।
7:28।
ठीक है, विल वेट
7:28।
देन विल, हाँ विल।
ओके सर। Sir, it's 7:30. So can I start? Hello.
Can we wait for a few minutes?
Okay, sir.
Acha, we have gotten we'll be having normally in this session few international participants. So I will suggest to keep all the talk in English. So it should be easy for the everyone to understand. ठीक है, Dr. Abhay?
Okay, sir.
Okay. So just wait for 4-5 minutes and then we'll start.
Okay, sir.
7:35 you can start. Okay.
Okay, sir. Volume increase क्या कैसे? Full कर दो. 100 है.
Okay, I welcome you all and Dr. Rabia. Dr. Rabia is assistant professor in National Institute of Cardiovascular Diseases. She is a she is a supervisor in College of Physician and Surgeon. So she will be talking today on management of patients with valvular heart disease. She has tried to make a talk just to help out all the examining candidates also. So if you want to ask the question, you can ask in the end of the case, or you want to leave in the chat box, you can leave it there. So she will answer the question. So Dr. Rabia, please
Thank you.
start.
Thank you so much. As already my sir has introduced me, so let's start with the topic of discussion. That is the management of patient with valvular heart disease. So in this talk, I will be discussing about the types of valvular lesion, different types of valvular lesions, their pathophysiology, hemodynamic concerns, their anesthetic management. We will also be discussing about the different case scenarios and patient with valvular lesion who are undergoing for non-cardiac surgery. One of the very important topic if the target audience are the resident. Okay, so in our routine life, what are the different type of valvular lesions we may have? Involving a single valve or both valve, that is the aortic valve or the pulmonary valve, and the pathology may be stenosis or regurgitation, and at times we may have a combination of mixed lesions that include the stenosis plus regurgitation as well. So remember, in mixed lesion, what we have to remember, we need to remember one rule, that with mixed stenotic and regurgitant lesions, we have to manage the dominant one. So before I start my topic of discussion, it is very important for the audience or the resident to understand the normal cardiac phases or the normal cardiac cycle in terms of the pressure volume loop. Here you can see a point A is the marking of mitral valve opening, which is followed by the ventricular phase of cardiac cycle. So this is the first phase which I am describing you here, which is followed by the, once the ventricles are filled, then it will lead to a closure of the mitral valve, followed by an isovolumetric contraction. Remember, during this phase, there is no change in the volume, but the pressure continues to build up. And this rise in the pressure causes the opening of the semilunar valve, which is an aortic valve. And once the aortic valve is open, then the cardiac phase enters into the phase of rapid ventricular ejection, which is here the green line marking. And once there is a rapid ventricular ejection, then it is followed by the slow ventricular ejection, which causes the fall in the pressure. Therefore, the aortic valve closure occurs, followed by a last phase, which is again isovolumetric relaxation, in which there is again no change in the volume, but the pressure continues to fall. So I hope I'm quite clear here with the different phases of cardiac cycle. It is important to understand it because once I will be talking about the pathophysiology through this loop, pressure volume loop study, we can understand it easily. Okay, here I am having a case scenario discussion. And through this case scenario, I hope I can make you understand about the pathophysiology of mitral stenosis and a patient with mitral stenosis who is planned for undergoing for non-cardiac surgery. So here, a 30-year-old male is scheduled for the right inguinal hernia repair surgery. He is recently diagnosed as a case of severe mitral stenosis and giving you a history of the short of breath on first flight of stairs. Remember, on first flight of stairs. So how will you assess this patient preoperatively? What is the functional capacity of this patient in terms of METs? What are the major clinical risk factors and the predictors of and the major clinical predictors which indicate the risk of perioperative complication in cardiac patient undergoing for non-cardiac surgery? So what is the etiology of mitral stenosis? In adults, it is predominantly secondary to the rheumatic heart disease, especially in the developing countries. Rheumatic changes are present in about 99% of surgically excised stenotic mitral valve. Women are affected twice as frequently as men, and rheumatic heart disease commonly affect the multiple cardiac valves and is often associated with both the stenosis and regurgitation. So stenosis, rheumatic Mitral valve stenosis is graded, which depends upon the normal valve area. The normal mitral valve area is about 4 to 6 centimeters square, and the patient is symptom-free once it is between 1.5 to 2.5 centimeters square. So in mild mitral stenosis, the valve area is greater than 1.5. In moderate, it is around 1 to 1.5, and severe is less than 1 centimeter square. And also you can see here the mean pressure gradient that may be less than 5 to 10, and greater than 10. And also the pulmonary artery systolic pressure less than 30 is in mild, 30 to 50 is in great, and greater than 50 is in case of severe mitral stenosis. So as I described you earlier, the normal pressure volume loop. Through this slide, I hope I am capable to explain you the pathophysiology in mitral stenosis. What happens that mitral valve is open during the diastole phase of cardiac cycle, in which there is a ventricular filling. Once the valve opening is stenosed or narrow, then there will be a narrow opening compromising both the end diastolic as well as an end systolic volume. Therefore, the left ventricle filling pressures are reduced, resulting in overall a decreased stroke volume. Here you can see in this diagram, the normal blue dotted lines are indicating a normal pressure volume loop, whereas the green line is indicated a decrease in both the end diastolic as well as an end systolic volume in case of mitral stenosis. I hope I'm quite clear regarding the pathophysiology, which is one of the most important component to understand in case of valvular pathology. Here I'm showing you a video which is telling you the typical appearance of anterior mitral leaflet, which is a diastolic doming of an anterior mitral leaflet. And in this diagram, you can see the dilated left atrium, which is showing you demonstrating a smoky appearance, which tells you the low flow state in mitral stenosis. ये मुझे disappear करना है. Slide stuck हो गई. Next. Okay, in history and the clinical examination, in rheumatic, I'm sorry for the delay, just it was, in rheumatic mitral stenosis, patients are frequently asymptomatic for a period of 20 years. It's a big period where the patient remains asymptomatic. However, as the stenosis develops, symptoms appears and associated at first with exercise or the high cardiac output states. What are the high cardiac output states? Include the anemia, pregnancy, thyrotoxicosis, and fever. So without surgical intervention, 20% of the patient in whom the diagnosis of mitral stenosis is made, they die within 1 year, and 50% die within 10 years following the diagnosis. So the degree and the progression of the disease depends and varies from individual to individual. So natural history also, there is a list of the symptoms, but I have included to mention you the involvement of the left atrium and its dilatation, how it's going to have an impact on the patient. The natural history is quite slow, progressive, and downhill course with repeated episodes of fatigue, chest pain, palpitation, short of breath, paroxysmal nocturnal dyspnea, and may have the pulmonary edema if the pulmonary artery hypertension is there, and may cause hemoptysis and hoarseness if there is a involvement of left recurrent laryngeal nerve, which is again caused by the distended left atrium and enlarged pulmonary artery. As long as the pathology becomes, involvement is more. Symptoms often becomes apparent with the onset of an atrial fibrillation. Remember, what these patients may have an arrhythmias, and atrial fibrillation is very frequently encountered in this patient. And patients with this are at increased risk of left atrial thrombi and subsequent cerebral or systemic emboli, and that's why these patients have to be keep on an anticoagulant prophylaxis. Mitral phases is a malar flush on cheek, and signs of right heart failure, tapic epic beat. As I told you, they have a mid diastolic murmur. In routine investigations, we may have findings on ECG, that is the P mitral, which is secondary to the left atrial enlargement if there is a sinus rhythm. Otherwise, we may have commonly this patient with atrial fibrillation. Absent P wave with an irregular rhythm. X-ray findings may have a valve calcification, straightening of the left heart border may be there, and curly B line secondary to the pulmonary edema. It is important to have the echocardiography of these patients in the preoperative period, which will tell us the mitral valve area, gradient across the mitral valve, left atrial enlargement, and the left ventricular functions, and the rest of the routine labs if it is required. So assessing risks in cardiac patient, there we have a New York Heart Association classification, one of the very famous and commonly in practices, a functional classification of physical activity for the cardiac patient. So class 1 are the patient with no limitation of activities, class 2 with slight and mild limitation, and they have a mild history of dyspnea. In class 3, there is the marked limitation of activity with moderate dyspnea, and in class 4, symptoms even occur at rest and they are severe dyspneic patient. In joke activity, although it's a very subjective method to assess the patient functional status at various level of activity, but I would emphasize for, especially for the resident, if they keep remember, so they can easily classify the functional class of the patient and help them to understand the severity of the pathology. So one can go through it. Okay, remember, if we have any patient with a severe valvular disease or severe valvular stenosis or regurgitation, then it comes under the heading of a major perioperative clinical risk factor as a predictor for perioperative complication. So this is a recent ACCHA guidelines which identify the condition that are the major cardiac risk and warrant an intensive management prior to the surgeries. Okay, in the perioperative care involves that the asymptomatic patient usually tolerate the non-cardiac surgery well. Patient with the poor functional capacity of less than 4 minutes needs to be considered for the mitral valve replacement. And spinal and epidural anesthesia may be hazardous in this patient with severe mitral stenosis. So if these patients are there in intraoperative, then there are certain goals that we need to follow. So their goals of perioperative management involve that we have to keep the afterload and preload and afterload we have to increase, and we have to maintain the contractile state. Heart rate should be in low normal limits, otherwise it's tachycardia, and this patient will further compromise the diastole phase as it will be shortened, and we have to avoid all these factors which will aggravate the pulmonary vascular resistance, such as hypoxia, hypercarbia, acidosis, HINs, or avoiding hypovolemia as well. Okay, here we are done with the mitral stenosis. Now, mitral regurgitation may involve a course of acute to a chronic. Acute, which is having a sudden onset, whereas a chronic, which is having a slow indolent courses. What in acute mitral regurgitation may be from the papillary muscle dysfunction due to myocardial ischemia or a blunt chest trauma, chordae tendineae rupture caused by the myxomatous regeneration of mitral valve, or an acute rheumatic fever, and can acutely deteriorate as a result of an infective endocarditis, balloon valvuloplasty, or penetrating chest injury. While in chronic mitral regurgitation, there may be an involvement of mitral annulus dilatation, disorders of mitral leaflet, disorders of subvalvular apparatus, and functional mitral regurgitation is ischemic mitral regurgitation, which is a type of a functional that is caused by a ischemic heart disease. This diagram is showing you a very famous Carpenter classification of mitral regurgitation, which is based on the involvement of the mitral leaflets. So in the first right on my top left, there is a normal mitral valve anatomy. Next, we have the mitral valve prolapse, and there may be a ruptured cord mitral valve, and finally there is an annular dilatation. So actually there are class 1, class 2, 3, and 3B, which is the Carpenter classification of classifying mitral regurgitation. Okay, let's discuss to understand this pathology of mitral regurgitation in terms of pressure volume loop. You can see here, okay, because of the normal compliance initially of the left atrium, the sudden volume in case of an acute leads to a significant increase in left atrial pressure that are passed on to the pulmonary circuit. As an immediate compensation for a decreased cardiac output, sympathetic stimulation increases the ventricular contractility and may also cause tachycardia. But there will be an acute increase in left atrial pressure along with the increase in the left ventricle and diastolic volume. While in chronic MR, there is a sufficient time for compensation. So there will be an increase in end diastolic volume, whereas the end systolic with a normal or without a significant increase in left ventricular pressure. And this is a diagram which you can see here. In acute MR, there is an increase in left ventricle pressure, while in severe chronic MR, the pressure may be normal or there is not a significant high until there is a serious or involvement in the pathology is further chronic. So mitral regurgitation grading is done on behalf of the regurgitant volume. In mild, it can be less than 30, moderate 30 to 59, and in severe, it is greater than 60. Regurgitant fraction and a regurgitant orifice greater than 0.2, 0.2 to 0.39, and greater than 0.4, which we observe in our transesophageal echocardiography as well. So this is the echocardiographic findings of mitral valve pathology in mitral regurgitation. Okay, again, there we have a video which is showing you a regurgitant volume across the mitral valve. This is a transesophageal echocardiography showing a two-chamber view and showing you a left atrium mitral valve and a left ventricle. In history and physical examination, one can have a history of fatigue, weakness, and dyspnea. Displaced and forceful epics that the more severe the regurgitation, the larger the ventricle. Soft first heart sound, apical pensystolic murmur. Remember, in mitral stenosis, there was a mid-diastolic murmur, but in mitral regurgitation, there is a pensystolic murmur and may have an atrial fibrillation as well. On ECG, may shows a left atrial enlargement or atrial fibrillation, X-ray chest, again, left atrial and left ventricular enlargement with mitral annular calcification. And echocardiography, we have to assess the degree of regurgitation. So in perioperative care, asymptomatic patient usually tolerate non-cardiac surgery well. Patient with the poor functional capacity of less than 4 meds needs to be considered for mitral valve replacement or repair prior to elective non-cardiac surgery. So these are the hemodynamic goals of managing patient with mitral regurgitation and intraoperative period. We have to decrease the afterload and we need to decrease in order to improve the forward stroke volume. And we have to keep the heart rate in high normal limits to promote the forward stroke volume and to reach an adequate stroke volume overall. And we have to maintain the loading condition and we need to keep the pulmonary vascular resistance as low as possible, avoiding all those factors which can further aggravate the pulmonary artery hypertension. As I told you earlier, these include the acidosis, angina, hypoxia, and hypovolemia. Okay, patient with MR regional can be given for NYHA class 1 and class 2, but general anesthesia is for class 3 and class 4, depending upon the severity of the valvular pathology. I'm done here with the mitral valve. Now let's start discussing about the aortic valve disease. So in aortic valve, we may have an aortic stenosis as well as an aortic regurgitation. Here I'm discussing
Dr. Rabia, we can't hear you.
Okay, sir. Slide sheet now. High aortic stenosis. A 40-year-old woman is scheduled for radical mastectomy. She is a known case of aortic stenosis. She gives you the history of the chest pain on severe exertion, like scrubbing a floor, but can climb first flight of stairs. Pressure And diastolic pressure is also elevated with a steeper diastolic slope, reflecting a diastolic dysfunction with an altered left ventricle compliance. So here I can tell you that aortic stenosis, there is a fixed cardiac output, the ventricular pressure are increased because they have to work against the narrowed valve. This will lead to a compensatory concentric hypertrophy, in which there is increase in the left ventricular muscle mass. So grading of aortic stenosis is again done on behalf what is the size of the normal aortic valve, that is about 2.5 to 3.5 centimeters square. In mild aortic stenosis, the size is about 1.5 centimeters square and the pressure gradient is 12 to 25 millimeter of mercury, while in moderate around 1 to 1.5, severe less than 1, and critical aortic stenosis is less than 0.6 centimeters square. Uh, you can see here in this picture, there is, in case of an aortic stenosis, there is an incomplete opening of the aortic valve during the systole phase of cardiac cycle. And that's the reason it produces ejection systolic murmur. This is the echocardiographic findings of an aortic valve. In my leftmost, this is showing you a 5-chamber view or a clear 3-cusp of the aortic valve, showing narrow of the valve curves. So I hope through this I have just included in this presentation to make a clear vision how does this aortic valve appear on the echocardiography and how this transesophageal echocardiography is helpful during an intraoperative management if these patients develop any serious complication. Okay, in history or the symptoms the survival depends upon the onset of the symptoms. First, the patient may have an angina pectoris, which is the initial symptoms in approximately 2/3 of the patient. Life expectancy when angina develop is about 5 years. Syncope is the first symptom in about 15 to 30% of the patient. And once the syncope develops, average life expectancy is reduced to 3 to 4 years. And finally, we have this congestive heart failure, the late sign to appear, symptom to appear. And once the left ventricle failure occurs, the average life expectancy is only about 1 to 2 years. Okay, in unicuspid aortic stenosis often present in infancy, patient with congenitally bicuspid aortic valve, they had usually a very slow onset of the symptoms, and it involved any times between 15 to 65 years of age group. Degenerative stenosis of tricuspid aortic valve usually develop in the 7th or in 8th decade of life and have a very late onset. Patient with the rheumatic aortic stenosis may be asymptomatic for 40 years or more. So in this patient, we may have a slow rising pulse with a narrow pulse pressure. And as I told you earlier, it will give the ejection systolic murmur, which is heard best in the second intercostal space along the right sternal border radiating to the neck. ECG may shows the sign of left ventricular hypertrophy in the brain with secondary ischemic changes. Chest X-ray remains normal until the left ventricle begin to fail, and there may have a post-stenotic dilatation of the aorta and a calcified aortic annulus may also be seen. An echocardiogram will enable us for the calculation of the valve gradient and assessment of left ventricular compliance. Cardiac catheterization is necessary to estimate the gradient across the valve and quantify any concurrent coronary artery disease, especially in elderly group of patients. Symptomatic risk assessment. Symptomatic patient for elective non-cardiac surgery should have an aortic valve replacement first, as they are at great risk of sudden death perioperatively. Remember, this is a very high risk of sudden death. Asymptomatic patient for a major elective surgery associated with a marked fluid shift or a massive blood loss, that is including thoracic, abdominal, or major orthopedics with the gradient across the valve greater than 50 millimeter of mercury, should have the valve replacement prior to the surgery. Asymptomatic patient for an intermediate or the minor surgery generally do well if they are managed carefully in perioperative period. So general anesthesia may be a good or a better choice. Limb blocks can be used alone or in conjunction with the general anesthesia, especially in the limb surgeries. I think it's a very good option. While central neuroaxial block must be used with extreme caution because of the danger of hypotension, due to afterload reduction once there is a peripheral vasodilation. So patients with severe AS have a fixed cardiac output, and they usually cannot compensate for a reduction in SVR and may develop arrhythmias in very high risk. And I can say it can be a relative contraindication for a patient with AS or aortic stenosis. So what are the goals of managing this patient in intraoperative? We have to keep the low normal heart rate. Tachycardia in this patient is deleterious because we have to avoid all those factors which can cause a sympathetic stimulation. Once there is a tachycardia, again there will be a shortened diastole phase of cardiac cycle, and there will be an impaired uh, filling of the ventricle. So we have to maintain the normal sinus rhythm, as 40% stroke volume is contributed by the atrial kick in this patient, as compared to the normal in which it only contributes about 25 to 30% of the cardiac output. We have to keep the high SVR and an adequate volume in this patient. In these patients should be managed in high dependency unit or an intensive care unit in post-operative period, have an adequate fluid and electrolyte balances, and we may need for infusions of vasoconstrictor that may be required to maintain hemodynamic stability in this patient. And we must have a good pain management in this patient to avoid any tachycardia or avoid any sympathetic response. Okay, now we are going to discuss an aortic regurgitation and the patient with aortic regurgitation for the non-cardiac surgery. A 40-year-old female is scheduled for cholecystectomy, and on her pre-operative assessment, she gives a history of dyspnea, palpitation on climbing first flight of stair. On her general physical examination, there is a water hammer collapsing pulse, DMAT and Corrigan sign positive. What are these signs? We will be discussing in later part of our presentation. On auscultation, we have a diastolic murmur, which is in second intercostal space along the right sternal border. So what is the most probable diagnosis in this case? How do you assess the functional capacity of cardiac patient for the non-cardiac surgery? What is the functional capacity of this patient in terms of meds? And what would you suggest regarding the surgery? And what are the hemodynamic goals in such a patient? So aortic regurgitation may have a primary cause, which may be a rheumatic disease or infective cause like bacterial endocarditis. And the secondary causes include the trauma, aortic dissection, and Marfan syndrome. Again, aortic regurgitation may be acute or can be a chronic. In acute, end diastolic volume is increasing with a high end diastolic pressure. Remember, we need to understand this different cardiac dimensions on echocardiography. And end systolic volume is also greater than the normal because of the regurgitation during isovolumetric relaxation, during which the aortic valve should be closed normally, but there is an inadequate closure allowing a regurgitant volume to backflow occur in the left ventricle. Therefore, there will be increase in the end diastolic volume. But in acute aortic regurgitation, there is also an increase in end diastolic pressure because little time for compensation. So this you can see here the normal pressure volume blue graph, which is represented by the blue dotted lines as compared to the acute AR, showing you a increase in the end diastolic volume along with an increase in the ventricular pressure. While in chronic aortic regurgitation, there is a sufficient time for compensation. So heart can be enormously dilated, but end diastolic pressure is relatively normal. And as a result of the chronic myocardial remodeling, which is a change in the shape and the size of the heart in response to chronic injury, and due to chronic diastolic volume load. So you can see here as compared to the previous slide, there is increase in diastolic volume, but not increase in the pressure as remarkable as in acute phase of aortic regurgitation. So this is the aortic regurgitation grading, which is based on behalf of this regurgitant volume, fraction, and regurgitant orifice area. This we need to go through and we can understand the severity of AR. Okay, this is an echocardiographic finding on this is on my leftmost. This is a transesophageal echocardiography, which is showing you a long axis, and here you can see the regurgitant volume across the aortic valve. Okay, so let's discuss about the sign and the symptoms in this patient. Patient with acute AR are not capable of maintaining the sufficient forward stroke volume, and they often develop sudden severe dyspnea, and therefore they may have a cardiovascular collapse and they can deteriorate rapidly. Patient with the chronic AR may be asymptomatic for many years. Symptoms such as short of breath, palpitation, angina usually develop after a significant dilatation and dysfunction. There will be a widened pulse pressure. We can see on the monitor. Collapsing is a water hammer pulse. Corrigan is a visible neck pulsation. The muscle sign, as we discussed earlier in the case scenario, is the head nodding. And I have seen this patient with the head nodding in AR. And Quincke sign is a visible capillary pulsation in the nail beds. Diastolic murmur, which is loudest in the second intercostal space at the right sternal edge. This is an extra chest that may shows the cardiomegaly or a prominent aortic valve. Your internet connection is unstable. And a left ventricular hypertrophy. Can you hear me?
Ji,
Can
we
it?
can hear you. Yeah, we can
Oh,
hear you.
okay, thank you. And an echocardiography gives a qualitative analysis of the degree of regurgitation, as I showed you on our previous slide that was telling us the regurgitant fraction and the volume and showing the severity of aortic regurgitation. So, in their perioperative care, asymptomatic patient usually tolerate non-cardiac surgery well, but patient with a functional capacity less than 4 minutes, unable to climb a first flight of stairs, need to be considered for the valve replacement prior to the surgery. What are the anesthetic goals in perioperative management? We have to keep their high normal heart rate. Otherwise, if there is a bradycardia, this patient can't maintain the normal stroke volume. So keeping a heart rate around 80 to 90 beats per minute is quite optimum for this patient. We have to keep the low SVR, we have to maintain the preload, and we have to keep contractility in normal. So this slide is just a review. This I talked earlier in my presentation that if we have a patient with the combined pathology, then we have a typical management and we need to follow the dominant one. And this is not a new thing for me as we are working in cardiac setup. So we usually have a patient who are the candidate for the double valve replacement. So in this patient, this chart can just tell you the target for the management in patient with the combined pathology. Again, there is a comparison in between the aortic stenosis alone and with mitral regurgitation alone. And if we have both the pathology, then we have to keep the left preload, increase preload, maintain heart rate, maintain contractile state, and also have to maintain the SVR. Again, there is a comparison between the aortic stenosis alone or a combination of regurgitation. So again, we need to maintain and we have to manage the patient with the dominant lesion. And this comes in the head, this comes like a severe AR or a moderate AS, and this is based upon the severity. So these slides are just here to compare if somebody comes with a combined pathology or involvement of both the valves. So I have not discussed about monitoring of this patient. So this is a single slide that indicates significance of monitoring of these patients who are having a severe valvular pathology in perioperative period. So invasive monitor are required to safely administer anesthesia. Arterial catheterization has become a standard in monitoring the cardiac surgical patient or the patient who are having cardiac issues or valvular pathology undergoing non-cardiac surgery. Central venous access is obtained for a careful fluid balance if it is required, and also for the placement of pulmonary artery catheter in very selected patient. So this is just a review that if what the significance of keeping or placing pulmonary artery catheter. It measures the pulmonary artery pressure, right ventricle function, pulmonary vascular resistance, and left atrial filling pressure. Pulmonary capillary wedge pressure is more direct estimate of left atrial filling pressure. And this not necessarily need to place in every patient. It depends upon the severity and if it is really required. Okay, the role of transesophageal echocardiography has been remarkably increased, and I'm pretty sure that if somebody among any of the audience is working in the cardiac setup, they are having a very regular transesophageal echocardiography that is done in the intraoperative period, and it also guides us the cardiac different heart dimensions, and it has a great significance. Like a decision can be made on this, and in my setup, our seniors are routinely doing it. So TE can be used as a diagnostic tool to diagnose an unanticipated problem and complications, and can tell us about the global and the regional left ventricular systolic and diastolic function, which can be assessed qualitatively or quantitatively. TE assessment of new left ventricular regional wall motion abnormalities is a most sensitive bedside monitor of myocardial ischemia occurs in this patient within perioperative period. So here we can conclude that the patient with valvular heart disease should be worked up for the severity of valvular lesions and functional class status determined before the urgent or elective surgical operation. And if the valvular lesions are far advanced, first cardiac and later the non-cardiac surgery should be done. Thank you.
Thank you very much, Dr. Rabia. It was a nice presentation. Now the forum is open for the question answer. If someone wants to ask the question, he or she can ask the question.
Who is talking?
Hello,
Yes,
Rabia.
yes,
I have a
please.
question.
Yeah, yes,
If
please.
aortic stenosis and aortic regurgitation both are severe, तो हम which one should we target? हम किस management पे manage करेंगे patient को? ART या AS वाली?
Dr. Rabia.
If there is a severe pathology or severe, then we have to keep the we have to maintain their hemodynamics. There should not be a marked hypotension, there should not be a marked hypertension, there should be not very high tachycardia. So we have to maintain the hemodynamics, and usually it happens there may be a severe aortic stenosis with a moderate regurgitation. So keeping the hemodynamics in target, or you can also compare from the baseline. The purpose of telling this is to emphasize that whatever the drugs which we are using during the induction period, some of them have a marked vasodilation. So if a patient with we are choosing the drugs which is producing marked vasodilation in aortic stenosis, the patient usually can't maintain the hemodynamics or the blood pressure. So we have to maintain the SVR. We can't even keep it in very normal low limits of 90/60. You have to compare it with the baseline. And I think this comes with experience and with the routine management of this patient. There is not a spot diagnosis. And
Okay,
Dr.
thank you.
Amin, if you can add anything.
Yeah, you are absolutely right. So as you said, so we have to manage and manage according to the plan what you have said. Absolutely right, and this is the practically we are doing.
So better to choose a group of drugs which causes less hypotension. Here we use etomidate in this patient, which causes less, which maintains cardiovascular stability. But you cannot, you have to give the drugs in a titratable states. You can't give it like a bolus. So you have to monitor the blood pressure and you have a control on your drugs because these patients shows are remarkable changes in the hemodynamics. And I think one who are monitoring or doing induction, they know how to manage it accurately.
Dr. Rabia, can you hear?
Yes, sir, I can hear you.
Yeah, there are a few questions in the chat box. Like, can we give epidural for moderate aortic stenosis patient?
Can we give epidural? Okay. It's better to avoid any regional. If we have a opportunity to give peripheral nerve block, then we should follow it first. And if you are doing epidural, then we have to be, in a very controlled fashion. We have to be avoiding, if it is accidentally intrathecal, then one can know the hazards of this. So it's better to avoid in moderate to severe. If we have a possibility of peripheral nerve block with general anesthesia, then yes, we can go ahead. Why should we take a risk? It also depends upon the facilities of the individual centers. If we have proper monitoring, proper post-op recovery, or ICU management, then we can. But
Yeah, this question was asked by Dr. Osman Ahmed. So
okay,
hopefully, and another question is sent by Dr. Bushra Jamali. She is asking, is PA catheter a better modality to monitor monitor patients in severe MS, or is transesophageal echo better?
okay. This is a very nice question. I want to answer that. Remember, PA catheter also involves the expertise as well. And transesophageal echocardiography is a very useful tool. It is less invasive. It is very easy. One can monitor through it. And I think PA catheter, if there are coexisting condition, if the patient is having the ECG finding of bundle branch block, so it may be a relative contraindication. So it is, we can place it, but it has to be very careful, involve the required the expertise. But for me, the transesophageal echocardiography is a better option, and Dr. Amin is doing routinely, and I think sir can tell us how beneficial it is. Very interesting. You can see the cardiac chamber easily. You can see the left atrial enlargement. So if you can't calculate these things, so you have a better view on transesophageal. And in our routine practices, we are doing it on every valve patient. And this is very helpful. Even I think, sir, I can have an input from you regarding
Yeah,
the use of this transesophageal echocardiography.
yeah, I
It's
think
fantastic, I think.
Yeah, T is now replaced the PA catheter, although we can't deny the importance of the PA catheter. But T is non-invasive, and intraoperatively it tells you then and there the results of the surgery. And even in the advanced T, if you are doing the comprehensive views, so you can also calculate the cardiac output, cardiac index. We can do the PGTR to see the pulmonary hypertension, the PA pressures. So T is very helpful. So I will say most of the centers, now I'm talking across the Atlantic, most of the cardiac anesthetists, they are doing the T. Although PA has got its own importance, but T is non-invasive and much safer than the pulmonary artery.
Any other question?
Yeah, any question, please? Please fill the feedback form so you can get a certificate. Any
Thank
question,
you.
please? Okay, so we'll be finishing in the next 3 to 5 minutes. By the time you all should fill the form, so you will all get the certificate. Thank you, Dr. Rabia, for sparing time and giving in a very nice presentation. And it was an examination-oriented talk, and hope all the examining candidates have got the benefit from it. Thank you very much. Please fill the form before
Thank you
leaving the.
so much.
Thank you very much.
I'm also grateful for you to have Dr. Amin, and I'm extremely thankful for Dr. Amin Khawaja, and also thankful for the audience who have joined me. And I hope I, through this presentation, could be able to clear a few of the basic topics regarding the valvular pathology. It's not easy in one go through because it's very complex to understand.
Thank you very much. Thank you.
Thank you.
So we'll be finishing in the next three minutes. Please fill the form, please. Thank you, Rabia. Thank you very much.
Thank you, sir.